Tomorrow. All right. Okay. All right, let's get started. My name is Suzanne Giuffre, and I am a therapy ed instructor. I've been a therapy ed instructor for over 10 years. I have taught at PT programs for 25 years. Believe it or not, 25 years. I hope you're looking at me on my video going, no, she can't be that old to have taught in PT programs for 25 years. But yes, I have. Okay, so let's get going. Integumentary interventions. The group who was here early voted and we decided we were going to start with interventions. I don't know if I'll get through interventions and pathology, but we're just going to go and see how far we can get in an hour. Okay, here we go. As far as integumentary on the exam is about 5.5% of your licensure exam. So not huge, but if you've talked to people, you know that some people fail by a very small amount on the NPTE or pass by a very small amount. So we do encourage that you get through all the content. And so that you can get as many questions right as you can, right? So on the exam, on the NPTE, you're gonna have about 3 or 4 questions on integumentary examination, about 3 to 4 on differential diagnosis, about 3 to 4 on interventions. You're gonna have about 12 questions on integumentary. Okay. So, I use a lot of chat. I use a lot of polling just to make this interactive. I want you to test yourself, quiz yourself. What do you know? All right, so in the chat right now, can you tell me what might be one purpose for a wound care dressing? There's lots of different purposes, but really quickly, let's see if we can get edema control. Okay, so edema, edema probably you mean managing the drainage, okay? So yes, we manage drainage. Prevent infection, debridement, protection, infection, protect the wound, healing. Yes, okay, good job. All right, so let's take a look at it. Because you have to know the purpose of what you want to pick the right dressing, okay? So here's the different purposes. Sometimes I want a wound care dressing because I have a dry wound and I want to provide a moist environment, okay? Sometimes I have dead tissue in the wound and I want to debride it and get rid of that dead tissue. Sometimes I have too much moisture. I've got too much drainage. And so the dressing I pick is to absorb some of that. A lot of people said infection. Yeah, if there's an infection. Now, some patients still need to be on oral or IV antibiotics, but we can manage the surface infection and lower the bacterial load. Sometimes the wound is fine, but it's chronic and it's just not healing. It's not going anywhere. So sometimes I want a dressing to promote growth. Somebody said protect. Yeah, sometimes all we want to do is protect it and let the body do its own thing and let it heal, okay? Keeping it warm, yes. For a wound to heal, we need to keep it warm. Okay, so let's move on. Good job. So the ideal wound environment will be a wound bed that is moist, not dry, but also not super wet and tons of drainage. Warm, clean, no infection, no dead tissue. And then the wound can have granulating tissue and the epithelial cells can come in to close it, okay? So we're gonna do dressings first. There's tons of dressings on the market. There's new ones coming all the time. They're similar to drugs though. A lot of them you will need a prescription, but a lot of them they're generic and then there's brand names. You do not need to know brand names for the licensure exam. So all of your wound care dressings, just know the generic classification. And that's what we're going to go over tonight. Okay. So a couple more things. What does it mean when a dressing is classified as occlusive? Anybody have that one? Put something in chat. What does it mean when I say the dressing's occlusive? Or when might I want that? Occlusive, tight. Viable, okay. Prevents moisture from escaping, no air in. Okay, great. Basically what it means is I'm going to seal it so nothing can get out and nothing can get in. All right, so I'm not going to let the moisture out, but I'm not going to let infection in. Some of them, occlusive dressings will allow for oxygen to get in, but that's it. Okay, other dressings, think about if you just put a piece of gauze on a dressing, that's not occlusive, right? Because the drainage could, make the gauze soppy wet and seep out, or infection can still get in. It can make its way through the gauze. So that would be something would be non-occlusive. All right. So occlusive seals the wound to keep infection, moisture out, keep it warm, keep the moisture in, and something non-occlusive, it's fairly open to the environment, not completely, but fairly. Okay. Debridement can be selective. That means we're only debriding what we want to debride. We're only debriding the dead tissue. Non-selective debridement is a technique where we're debriding dead tissue, but we're also debriding viable or healthy tissue. So that is not preferable. Okay. All right, here we go. In the chat, what is the primary purpose for these? Primary purpose for a hydrogel or hydrocolloid. What do you got? Don't make it difficult. Hydrogel, hydrocolloid. Yes, to add moisture, to hydrate. Okay. I think we make wound care dressings harder than it needs to be. So I'm hoping that this chart will be very helpful. Okay. If I have a dry wound and I want to hydrate it, I want a hydrogel or a hydrocolloid. Okay. So they provide moisture, they hydrate. There's no absorption property because they're hydrating. That's the primary purpose. I think as long as you know the primary purpose of all of these, you'll be fine for the exam. But if you want a little bit more information, it does stimulate granulation tissue. It helps with the body debride itself. That's what autolytic debridement means. It means that the body, you're setting up an environment where the body can debride the dead tissue itself. Hydrogels come in gels, where you just squeeze it into the wound and then cover it with something else, or a sheet. You just put the sheet on, okay? And that sheet, if you want to use ultrasound for wound healing, you can do ultrasound right over top of that sheet. Or you squirt the gel into the wound and just do the ultrasound right over top of the gel. So does that mean you use that during minimal exudate? So with minimal exudate or healthy exudate, I don't use a hydrogel. The only time I use a hydrogel or a hydrocolloid is if it's a dry wound. Okay, so hydrocolloid, same thing. Main purpose is to hydrate. It also helps with protection. If you've been in the clinic and you've seen patients who have duoderm, that's a brand name, that's a hydrogel. Okay, again, you don't need to know duoderm for the exam, you need to know hydrogel. It has a little bit of absorption properties, but it's mostly to hydrate that wound. Again, it helps with debridement, granulation tissue. They're usually sticky, they stick right on so they can be occlusive. They're sterile, all the dressings are sterile. I don't even know why I have that on here. It will leave a residue. So when you peel it off, there is usually an odor and a yellowish color, but that's expected. Because as it's hydrating, the material in the dressing kind of melts into that. Sisicare is hydrogel. I'm not sure. I don't recognize that one. Okay, let's go to the next one. Why would we use an alginate or a foam? All right, we got a variety of answers here. I want you to think about a foam as a sponge. That usually helps people, right? So an alginate or a foam is for absorption, all right? So this is when we have tons of exudate. Okay, so hydrogel is when it's really dry, and alginate or foam is when it's really soppy wet and I've got tons of drainage, okay? So that's the main reason. Again, it can assist with granulation, debridement. These to me look like white felt. That's how I explain alginate. Sometimes on the exam, you might see it might say calcium alginate. It's the same stuff. Okay. It's made from seaweed. So people who are allergic to seaweed, you can't use it. They'll have an allergic reaction. It turns into a white gel. So after we use it and it sops up all the drainage, it turns into this like white gel that you pull out. That can be mistaken for infection. So the wound care team needs to be talking together to know what dressing that we're using. So they understand when they do a dressing change, what they're seeing. A foam, again, they come in all different sizes, shapes. You can cut them to fit the wound. Again, they're for absorption. All right, what are antiseptics and antimicrobials for? Okay, yeah, they're for infection. Okay, so that's going to be if it's going to kill infection. So if we got something that's infected, we can use an antiseptic or antimicrobial. All right, antiseptics, they're great at killing bacteria, but we do not want to use them for very long because they're cytotoxic. They kill the good tissue with the bad tissue. So they will actually, if you use them for a long period of time, the patients will get a chronic inflammation response, and it will actually interfere with wound healing. So these are great when you have somebody who comes in who has a really dirty wound, that you can I'm going to just hit it right from the get-go and kill all that stuff that's in there. But then we want to move away from this quickly. So they are cytotoxic, can prolong the inflammatory phase. Betadine, it's kind of unsure if that's really harmful. Dakin's solution, which is bleach, we can use for very dirty wounds. But again, we don't want to use it for very long. Hydrogen peroxide, you probably have some of that at home. Your mom might have used it with you. It only works for a few seconds. So when you pour it on, it bubbles and then it's gone. So you can use that, and then with a patient, kill the infection, wash the wound out with sterile water or saline, and then put a different dressing on. They're all in liquid form. You can get them in various concentrations. Antibacterials or antimicrobials are the ones we like better because they're not cytotoxic. They don't harm the good tissue. They only attack the bad tissue. So probably you have things like this at home. You probably have Bactrim, Neosporin, gentamicin. You probably have some of this in your medicine cabinet. Almost all of them come in gels. You just put it on the wound and then you have to cover it with gauze or something else. Some of the silver dressings come in anything. You can get silver now in gauze, in a hydrogel, in a hydrocolloid. Like you can get silver in anything these days. Silver's great. They're expensive, but they will kill 99.5% of whatever's growing in that wound within 2 hours. It does leave a residue. Again, it's a metal, so the team has to be knowing this. We can't have that patient go down for an MRI with a silver dressing on, because that's a metal. So, but we do like these. The reason I have Neosporin used sparingly is that if you use Neosporin on a big wound for a long period of time, the patient actually may end up not being able to use neomycin, which is an antibiotic, because they've kind of built up this kind of resistance to it. So that's why I have that there. Okay, cellulose and growth factors. This is a tough one, although think about what that is, growth factor. Think about what that is. Why would we use these two dressings? Definitely for healing, for tissue growth. Yep. So who would we need to do tissue growth on? Right? Hopefully everybody's like healing. So burns potentially. This is for people with chronic non-healing wounds. So if I'm doing everything right and the wound looks great and there's no infection and there's no dead tissue and it's just, and I've been waiting for the body to do its thing and heal it and it's not going anywhere, I might use cellulose or growth factors. I wouldn't worry much about this because I don't think you're going to see this on the NPTE, but I just like to put it in there. All right, transparent film. Oh, well, Collagen helps lay down a wound matrix. Can't use it if they're sensitive to cow material. They get the collagen from cows. Growth factor, you can buy it in a tube, or they can actually take the patient's blood and make growth factor from their own blood and send it back to you as a wound, as a solution to put in their wound to help with growth. So they're really kind of cool, but I don't think you're going to see that on the NPTE. All right, transparent film. Why would we use that? Sometimes they're called semi-permeable films. You've all seen these if you've been in the hospital. It's like a big piece of tape, and it's what they put over an IV. So you've probably seen them. Yes, somebody's got to protect and inspect. Yes, they are for protection. This is when the wound looks great. And all I want to do is seal it off, protect it. Transparent films are occlusive, so it's like a big piece of tape, doesn't let anything in, doesn't let anything out, and it'll just heal, okay? So it's just going to protect the wound, help it do debridement, keeps all the moisture in. You can't use it if they have a lot of drainage, because if you can imagine trying to stick a piece of tape on when they have a lot of drainage, it just slides right off, okay? All right, last one, wet to dry dressings and enzymatic debriders. Why might we want to use those? Yeah, I mean, I've got debridement right in there, right? It's for debriding, but we actually don't want to use wet to dries. If there is a question on the NPTE and it says, which of the following dressings is most appropriate? And one of them is wet to dry, get rid of it. That is never appropriate. We don't use them, okay? Very rarely would we use them, all right? Why not? Well, because it's a non-selective type of debridement. It's very painful when it's removed and it rips off the bad tissue, but also healthy tissue. A lot of times they aren't applied correctly. A lot of people don't know how to apply them. And then it causes issues with the surrounding skin because they're wet. And if they don't contain it just to the wound, the surrounding skin gets macerated, wrinkly, inflamed, and it'll break down and make the wound bigger. And so we don't want to do that. And then I have down there, if you were to do a wet to dry, basically you wet a piece of gauze with different types of substances, you kind of squeeze it out, stuff it into the wound, put a dry over top, wet to dry. And then when the wet gauze underneath completely dries and it's stuck to all that dead tissue, unfortunately it sticks to viable tissue too, you rip it off. And that's why it's very painful and we don't use it very much anymore. So if somebody does have necrotic dead tissue and we want to debride, we want to use an enzymatic debrider. So it doesn't harm the good tissue. It's usually a gel we put in there, an ointment. We have to put something over top like gauze, and then it just eats away at the dead tissue. So I put a couple names here just so you can have that with you, because those are more generic names. So if you saw one of these on the exam, I want you to say, oh my gosh, that's an enzymatic debrider. And some of them can, because it's eating up dead tissue, when you go to change the dressing, sometimes the dressing is coming off and there's all this greenish or yellowish or goopy stuff, but that's not a bad thing because that's all the dead tissue that's being broken up that's coming off in the dressing. All right, selective debridement, we already talked about that. We're only removing the necrotic tissue. So what would that be? Sharps. If we get in there with our scissors and our tweezers, we're usually only, I hope, we're only getting the dead tissue out. If you do enzymatic debridement and you have thick sheet of eschar, that really thick, adhered, dried sheet of dead tissue, you can do what's called cross-hatching. I have a little picture down here. What you do is you take a scalpel and you do these grids across, and then you put your enzymatic debrider on there, that ointment, and that ointment gets down into the little crevices that you just cut into that eschar, and it helps break it up. So that's what cross-hatching is. Maggots. Wow. Yes, but there are medical grade maggots that are sterile maggots that are selective. They're great. They're actually really great for debriding tissue. And then non-selective. This is what we don't want to do. We don't want to do wet to dry dressings. We don't want to do whirlpool because there's all kinds of problems with whirlpool, but one is it's non-selective way of debridement. So we're harming the good tissue along with the bad. Sometimes they do have to go in to have surgical debridement done. When they do that, the surgeon usually takes some of the good tissue too, to make sure they've gotten it all. So that's also non-selective, but sometimes that has to be done. All right, other dressings. There's antifungals. We would only use that if there's a fungal infection. Wound fillers are used when we just want to keep something warm. Gauze, like you've all seen gauze pads, that's usually used for a secondary dressing. So whenever we're using some of these ointments and creams or whatever, like we gotta put something over it, so we put gauze over it, okay? And composite dressings are when we mix dressings. All right, so again, antifungals, you know, if they have a fungal infection, ringworm, athlete's foot, whatever, they can be on an antifungal. The only thing really to know about antifungals is if somebody uses certain kinds for a long period of time, they can have issues with renal failure. So we would watch their bun and creatinine levels. Probably not going to see a lot of that. Wound fillers, again, they're just usually ointments, gauze, foam, and the purpose is just to keep it's usually a deep wound, and we're trying to keep the wound warm. So we have a filler. We never want to pack wounds tightly. If we pack a wound tightly, we're basically causing pressure on the wound. And so we don't ever want to do that. Gauze, again, you've seen gauze. It can be used for some absorption, but it's usually used as a secondary dressing. And then we have these gauze rolls that we can wrap around to keep whatever dressing on. In composites, again, it's when we mix 2 or more dressings. I always tell my students, don't ever do that on your own. If you're thinking, oh, I think I'd really like to use this antibiotic along with calcium alginate, you should never do that unless you talk to the manufacturer, you talk to the physician, you talk to the wound care team, because you don't know how those 2 things are going to interact. There are a lot of, like if you go to these big wound care centers, they do a lot of composite dressings, but they know what they're doing. Okay, so don't do that unless you talk to the medical team. All right, let's talk more about interventions. What would you include in your PT intervention for prevention of wounds for those that are at high risk? So just give me one thing in the chat. So down there at the bottom, I've got it. They've got increased age. Maybe they have diabetes. Maybe they've had a spinal cord injury. They've been in the ICU for a long time. They have incontinence. Yes, great. You guys have got it. Positioning, skin checks, patient education, information about nail care, footwear. Yep. Hygiene, positioning. Good. Okay, let's look at my list. Yeah, pressure reliefs. Teaching them all different kinds of pressure reliefs, positioning, equipment. There can be questions on the exam about their need for equipment. Maybe they need a wheelchair cushion. Maybe they need a special bed. Maybe they didn't need a long-handled mirror to do daily skin checks. Proper foot care. They should be washing their feet, drying them, especially between the toes so they don't get fungal infections. Wearing clean socks, properly fitting shoes. They should inspect their shoes, which I tell patients, don't just look in your shoe, dump it over and shake it, right? Because if you look in your shoe, you may not see that little pebble there, but when you dump it over and shake it, that pebble might come out. Checking the water temperature. I've had patients who step into a hot bathtub and burn their feet because they didn't know how hot it was, and because they have neuropathy on their feet, they didn't feel the temperature. So I always tell them, check the water temperature with a part of your body where you do have good sensation before you get into that shower or you jump into that bathtub. I actually had a patient who got burned on one side of her body because she'd had a stroke and she didn't have good sensation on one side of her body. She got in the shower and she was washing on one side. When she turned, she felt how hot it was, but she had already burnt herself. Actually, she ended up in rehab. She actually passed away from her burns. So want them to check on that for sure. Wear schedules, right? New shoes, new orthotics, right? They shouldn't wear them 8 hours a day right from the get-go. We want to teach them about proper nutrition, hydration. We might look at lab values like prealbumin and albumin to see if they need a referral to a nutritionist or if they're not getting enough hydration. Incontinence, maybe they need to manage their incontinence better. Maybe we need to refer to their another healthcare provider. We want them to keep their skin moist, but we don't want them to put lotion in their wounds, of course, and not between their toes. And they should see podiatrists for nail care. All right, good list. All right, let's go on to burn management. So here's what I want you to think about. If I burnt the front of my neck, what would the deformity be? And what position should I position the patient in? And that might be just a certain position or getting them an orthotic or a splint or something like that. Yeah, you guys are awesome. Yeah. There are going to be questions, there can be questions on the exam about managing contractures with burns. I don't think this is really hard. Just think about whatever's burnt is going to contract. So if I burned my anterior neck, that's going to contract. My deformity is going to be neck flexion. And so what I need to do is do hyperextension. So as you can see, I might lay that person in bed with their neck in extension as much as I can get it. I might also get them a neck brace for during the day to keep that burned area stretched out. What if the burn covers the front and the back of the neck? Okay, that's a great question. Then we would alternate. So we would position for a certain amount of time in flexion, certain amount of time in extension. We would get them doing a lot of active range of motion, and probably during the day, we would get them something just holding them in neutral. That's a great question. All right, think about the shoulder. What do you think about the shoulder? What is the typical deformity of the shoulder? Now, it really does matter exactly where the shoulder was burned, but typically we are seeing adduction and internal rotation. So most people that have a burn of the shoulder, we do the airplane splits. So we're doing abduction and external rotation. That is what we want to do with a burn with the shoulders. Can hyperextension cause vertigo? What can be done about that? So there are going to be some people who can't do the hyperextension. So we're just going to put them in as much extension as possible. It can present other issues, right? So we would want to check for how they were managing that and how long they might be able to be in that position. But some people won't be able to do it. Good question. All right, elbow. What do you guys think about the elbow? What is the typical deformity? Okay, people are saying flexion. Yeah, flexion and pronation. So typically we're going to do extension and a supination braid split. Okay, and sometimes this is OT, but sometimes it's not, right? Sometimes it's us, so we need to know some of that. All right, what about the hand? What's going to happen with the hand? Yeah, they're going to get flexion contractures. They're going to get claw hands. Everything's going to flex up and probably start to adduct and just kind of pull their hand into these claws. If the wrist is involved, we want to do some wrist extension, and we want to get the MCPs in flexion, the IPs in extension, and abduction. And so you can see an example of a splint that might be used for somebody. All right, what about the knee? Yeah, flexion. Yeah, typically we're gonna have them in flexion. That's gonna be the issue, and so we're gonna just put them in an extension. And again, we're putting them in these braces. We're doing these positions, but clearly we want to get them out of these braces and out of these positions and be doing range of motion. But it's just when they're static or when they're sleeping, we want to have them in these positions. So while they're sleeping, they're not getting a lot of contraction going on. All right, last one, ankle. What do you think? What's going to happen with the ankle? Yeah, plantar flexion. Yep, you're right. That's typically what we see is plantar flexion. And so we're going to put them in dorsiflexion or neutral. with some kind of splint or AFO. And again, depends on where the burn is. If the burn's on the back of the leg, my device, whatever I'm going to have fit for them, is going to be on the front of the leg. If the burn was more on the anterior part of the leg. So I'm always thinking about where the splint is, because I don't want to interfere with the burn healing. Yeah, do you place it on top of the dressing? You can place the brace on the top of the dressing, yeah. But we also want to be thinking about, where is that burn? How is it healing? Is there a skin graft? So we want to be talking about with our healthcare team, can we put this splint in this location, or do we need to move it somewhere else, or do we need to stop using it for a while? Maybe while that skin graft is healing, we can't use it. So we're gonna, but this is just, you know, general information I would know for the exam. Okay. Additional information about burns. After a skin graft, they're usually on hold for at least 2 to 7 days. So it depends on how big the skin graft was and stuff. Or at least they don't want you mobilizing that area for 2 to 7 days. So you want to, you know, talk to the surgeon. Pressure garments. We don't use pressure garments until that skin graft is completely healed. And then we are using it to prevent scarring. We don't want to get the keloid or hypertrophic scarring. Best method, they say, to prevent contractures is to do to do active range of motion every 2 hours within the first 24 hours of admission to the hospital. Like constantly, let's do active range, active range, active range. Whether we're doing it, the nurses are doing it. It's possible maybe that the family member is doing it. If we cannot, I'm sorry, active range. So the patient's doing it, I'm sorry, but we may have to have other people reminding the patient to do it. If they can't do the active range, then we would do passive range, but hopefully they're gonna every 2 hours, you know, be doing their active range of motion within those first 24 hours. That's a great way to help with prevention of contractures. We kind of already went over dressings. A lot of the wound care, a lot of the dressings for burns are because they're at high risk for infection. So a lot of these are used to prevent infection. Some are used for to help with debridement. Okay, I think I saw another. What would be the anterior chest or the trunk burnt? Okay, so if the anterior chest was burnt, obviously they would go into a kyphosis. And so we would want to promote the upright position. We would want them laying in bed in extension. If the back of the trunk was burnt, that's not as big of an issue though. But because if it causes, it can cause, you know, it causes them to be extended. The problem is they're then not going to be able to do flexion. So then we would want to make sure that during the day we're doing a lot of flexion movement, or maybe even in bed, have them curl up and be more in flexion. Okay. What is one reason or criteria when considering using Whirlpool? I don't even know where I'm going with this, so let's see what I had. Okay, so we don't really use Whirlpool, but they say if you're going to, the wound has to have 20 or 75% or more dead tissue that needs debrided. They say really you should only use the Whirlpool if it's already infected, not healing well, because it is a non-selective way of debridement. So, but they say you really shouldn't use the Whirlpool if it doesn't need a lot of debridement. If it's not infected and you put them in the Whirlpool, you're running the chance that they could get infected because maybe it wasn't cleaned really well after the last patient. If the wound is healing well, don't add Whirlpool. Okay, so there are a few instances where we might use Whirlpool, but typically not. Okay. Probably the only time we use Whirlpool nowadays is when we have somebody who comes in with burns and we need to do some debridement, and the Whirlpool will help with some of that, but that might be the only time we even consider it. Okay. I don't think you need to know this for the exam because we're not going to really use Whirlpool. But if we do, just remember that you usually want to be that 92 to 99 degrees. If they have peripheral vascular disease or sensation loss or neuropathy, it's got to be cooler. But we have to be careful. We don't want somebody to burn from it, right? So we really don't want to exceed 102 degrees. Pulsatile lavage, it's possible you could see this on the exam. It's basically for any wound. There's no known contraindications. We'd rather use this than Whirlpool because it's safer. We can dial in exactly the amount of pressure that we want. Everything's sterile. Everything can be thrown out. We don't run the risk of cross-contamination. And so, you know, you could possibly see something on the exam about this. This is primarily done for debridement. They have added vacuum-assisted closure to the NPTE. In 2024, this was added. I struggle with what are they actually going to ask you? I think what they're going to ask you is why you would use it. But basically, it's a negative pressure. It's a vacuum that pulls at the wound, and basically it brings the edges of the wound together. It helps remove infectious material and helps promote granulation. So I think what I could see on the exam is they give you some kind of patient scenario where it's like a chronic wound. It's, you know, there's maybe there's some drainage, but it's not infected. It doesn't need debrided. It's just not going anywhere. And they might ask you what might be an appropriate intervention. Well, vacuum assisted or negative pressure wound therapy would be a good way to go. So basically they put this foam in the wound. They have this tube that's coming out of it. They put a transparent film over top, so it's all sealed. And then it's hooked up to a machine, a vacuum, and that machine is constantly sucking or pulling to get whatever's in the wound out of it and to bring the edges closer. Okay, so hopefully that will help. E-stim, we can use E-stim for wound care. So again, there could be questions about that. Primarily, we use high volt. Things to know is we want a positive charge for epithelialization, or if we're just trying to get the wound to go through the inflammatory phase. We want a negative electrode if we're trying to stimulate granulation or infection. Those are probably the big things to know. Ultrasound, we can use ultrasound too for wounds. We're going to use 3 megahertz if something's superficial, 1 megahertz if something's deep. Because we don't want the thermal effect, we want it on pulsed or like a 20% duty cycle. And our wattage, I don't think you need to know this detail, but the intensity should be low. Usually it's like 0.3 to 0.5. We don't need a high intensity. We don't want that 1.2 watts per centimeter squared because that's more for thermal. Okay. If it's a full thickness wound and you're like it's so deep that it's like right below the wound is like bone, we don't want to ultrasound over top of it. We usually do the skin around the wound to help it heal. Una boots, if you don't know anything about Una boots, these are semi-rigid wraps that we put on, kind of like a cast, but it's not as stiff as a cast. It manages edema. It protects the wound. It helps you offload the wound potentially. They're usually made from zinc or calamine lotion, which helps with healing. So they're great to use for certain patients. You don't want to use them if you have somebody with arterial insufficiency because you don't want to do any compression. You don't want to use, I should have had that one on here. You don't use it if it's heavily draining wounds with lots of drainage. You don't want to use it. Don't want to use it for an infected wound or a wound that needs debrided because you can't see the wound while they're in the Una boot. A lot of times what we'll do is we'll put an Una boot on for somebody with venous insufficiency because we want to manage the edema. We want to protect the wound and let it heal, but we'll put it on for a couple days. We'll take it off. We'll look at the wound. Everything's good. We put it back on. And then once we get the wound healed or closely healed, and we get that edema down, then we can switch to a different dressing and do like just like compression wrappings or custom compression garments or something like that. Okay. What else would you include in your patient education for a patient with a wound? So what haven't we covered yet that you would be like, I think I would educate them on? What might that be? When to change the dressings. Yeah, a lot of patients are going to be doing self-dressing changes. When to change it, how to change it, how to keep it clean, nutrition, hydration, signs of infection. Yep. How to keep it dry. Yep. Signs of infection, when to go back to the physician, when to call us. Yep. Good list. Okay, let's see what I've got. Signs of infection, signs of a DVT, dressing changes, pressure reliefs, positioning. Some of this we already talked about. Proper foot care, hydration, sensory changes, right? If I've got that Una boot on and their toes go numb, I probably got it on too tight. They better let me know. Yeah, so I think we covered a lot of these things already, but yep, good. Just some other patient education. If somebody has arterial insufficiency, I talk a lot about positioning. They already know. They know if they put their leg up, they're going to start having pain. But we might talk about how to properly position to sleep at night. A lot of them will sleep in their lazy boy chairs with their legs down. We do talk about risks of wounds, claudication pain. We might set them up on an exercise program to help with that claudication. So we can do those types of things. Venous insufficiency, again, it's positioning. They need to have their legs elevated. They need to do wrapping, use their garments. Again, they're at risk for wounds, but they need a lot of edema control. They want to avoid heat. They want to avoid the dependent position, anything that's going to increase their edema that they have. All right. So what we're going to do is we're going to shift to the pathologies really quickly. I do want to show you this though before I switch PowerPoints. If you're not aware of all the therapy ed resources, we do have a 2-day prep course. It's in person or online. I gave you the QR code there. It also includes our course manual. Oh, this didn't come out. I think this QR code down here is for our new app. Our new app has 600 questions. And so I think that's the QR code for that. Sorry about that. I don't know why that didn't come out. And then if you don't have our review and study guide, our big book, it also includes 3 full practice exams. The book comes in an e-book version or an actual physical one. So again, there's the QR codes for you. Okay. Oh, the one in the bottom is deactivated. Okay, thank you. Oh, there it is. It's the 600 questions. Okay, I'll have to look. So if you do want the mobile app, if you go to Therapy Ed's website, you should be able to find it. I tried to be techie, and I had a QR code thing that you change the website to a QR code. I thought it was being really good, but maybe I messed that one up. So thank you for letting me know that. Okay. Yeah, so if they didn't work, all of that's on the website. All right, so what we're going to do is we're going to shift really quick, and we're going to go ahead and go to the pathologies and see how much we can get done in the next 20 minutes. Because I don't want to get both things done tonight, but it's hard to do in an hour. Okay, here we go. Let's look at pathologies. So we already talked about this. Okay. Okay. Red flags for moles. What's the A for? The questions on the app, are they different than the book? They were getting there. I don't know if they're 100% there yet, but we've been switching them out. So if you need, I'm not sure where we're at yet, but my understanding is they're taking the questions that are on the 3 exams out of the app and putting different questions in. Okay, yeah, asymmetry. All right, so what are we looking for? It's a red flag if the mole's not symmetrical. Okay, now, if you look at some of the moles on you, okay, I have moles that aren't symmetrical. That it's just one piece of the puzzle. I'm not concerned yet. Okay. All right, B. I got people jumping to C, which is awesome. B, border. Yep, you got it. Okay. So border. The border has to be clearly defined. If it's not, that's a red flag. You guys said color. It should be one color only. Diameter shouldn't be any bigger than the eraser on the end of a pencil. I've seen questions where they ask you how big that is. And I'm like, really? Well, it's 5 to 6 millimeters. Okay. E, I like evolving. The mole has changed in the last few weeks or months. To me, that's a huge red flag. Some people say they've learned E is elevated, the mole's elevated. That's okay, but that's not as big of a red flag as evolving. Okay, look at this mole down here. Is it symmetrical? No, red flag. Is the border clearly defined? No, red flag. Is it one color? No, red flag. I don't know how big it is from this picture. Has it been evolving? I don't know. I'm going to ask the patient. Okay, it does look like it might be a little elevated. So I have enough red flags that I would be concerned. Okay, and this would be a referral that I would refer a patient. Okay, good. So melanoma is what we're really worried about. It's not just old people, right? Actually, the incidence is increasing in younger people. It's doubling every 10 to 20 years. Peak incidence right now is 40 to 60, but it's rising in that younger population. I've had 2 PT students have to take off time from school to have these removed. And I told them, you go do it. Because if these metastasize, you have a 1 to 5 year lifespan. These are bad. PTs have saved patients' lives by picking these up. So if you're not sure, don't scare the patient, but have somebody that's a little bit more knowledgeable about it look at it, okay? There are other ones, basal cell carcinoma, squamous cell. Those are usually pink or red or flesh colored. They're not as concerning, but I don't want to fool around with those either. They may not be an immediate referral, but I might tell the patient, hey, you probably should, if you're not sure what this is, have this looked at, okay? And the treatment for all of these would be for them to be surgically removed. All right, pressure ulcers, okay, which picture A, B, C, D goes with a stage 1? Yep, you got it. All right. Yep. So stage 1, the key here is it's intact skin. It is not open, okay? Non-blanchable erythema of intact skin, okay? All right. What is a stage 2? A, B, well, you got A, B, and D. Yep, B, you got it. Okay. So this is a partial thickness skin loss. It involves the epidermis, the dermis, or both. What I tell my students is there's no measurable depth. They're very shallow. Could just be an abrasion, a blister. So a blister is a stage 2. It's not a stage 1. It's a stage 2. You might say, oh, but if it's a blister and it's not open, that's a stage 1. It is a stage 2 because eventually that skin will come off. So they put it as a stage 2. All right, which one is a stage 3? I'm going to give you a hint here. This D, that's bone. All right, so which one are you going to do for a stage 3? Yeah, so stage 3, I tell my students as soon as they start to see fat, it's gone all the way through the skin. You're going to know that that is a stage 3, full thickness skin loss. Stage 4 is when we're seeing muscle, bone, tendon, ligament, and some sinus tracts that go deep would be a stage 4. Okay, good job. All right, I'm going to give you a few seconds here. Can you, just in your mind, look at the things in the middle and decide, is that a characteristic of arterial insufficiency or venous insufficiency? Let me give you a couple seconds here. Look at the whole list. I want you to just look at the whole list and see if you can quickly do a little sorting. But you're right, the first one, edema or swelling, would be venous. Okay, let's take a look. Let's start with arterial. Arterial insufficiency, very painful. They have claudication pain. They have ischemia. It can be very painful. They have dry wounds. So here we go. If I gave you a question on the exam and said, the patient that you're treating has arterial insufficiency, which of the following dressings would be most likely appropriate? What would you say? We already went over the dressings. What would you say was appropriate? Yeah, hydrogel or hydrocolloid. They don't even have to tell you the wound is dry. You should know that. Arterial insufficiency, they cannot get the blood down to the leg. They don't have a lot of blood. They're not going to have a lot of exudate or drainage. They're going to be dry wounds. We want that hydrogel or hydrocolloid. Very good. Arthrosclerosis goes with arterial insufficiency. They tend to have wounds on the lateral malleolus. How do you remember that? I've struggled. I've had students give me all different kinds of ways to remember it. The one that stuck with me, and I don't know why, but it stuck with me, is I had a student say, oh, lateral arterial, LA, Los Angeles. I don't know why, but it stuck with me. I'm like, oh, Los Angeles, lateral arterial. For whatever reason, it stuck with me. They have a pale wound bed because they don't have good vascularization. They have deep wounds because, again, they don't have good vascularization. They don't heal very well. They have wounds on their toes, the bottom of their foot, the top of their foot, because the further you go down the leg, the less and less blood they have, okay? They're going to have diminished pulses, increased pain with elevation. They don't want their leg elevated. They would have a positive ruber of dependency test. Okay, you should know a ruber dependency test. That's for arterial insufficiency. And so this picture over here is of somebody with arterial. Oh, arterial ends with an L. Okay, that's good. All right. I've had other people tell me things that I had somebody say, well, arterial and lateral have the same number of letters. And I'm like, well, they don't. Or arterial and lateral both have A's. I mean, a couple of different ways, but for some reason, Los Angeles and lateral arterial just stuck with me. And so I just tell people that one. Venous insufficiency. We're going to have a lot of edema, a lot of swelling. The issue is they have too much blood down there. They can't get it back up because the veins and the valves stopped working. They have excessive drainage. So what wound dressing? Alginate or foam? Yes. They don't even have to tell you the person has excessive drainage. Somebody with venous insufficiency, you should know that. So you're going to pick an alginate or a foam. They have good granulation tissue because they got tons of blood down there. They have good pulses. You will see probably varicose veins because that's kind of how it starts. Medial malleolus. All right. Medial malleolus. I had a student of mine said, oh, you remember that LA thing you told us? Lateral arterial. He's like, I got one for venous and medial. And I'm like, what? And he's like, Mount Vernon. He's like, medial, venous, Mount Vernon. And I'm like, okay. I'm like, now that one's stuck in my head. So these are shallow wounds. They will have increased pain in the dependent position because they have increased swelling. They want their legs up. And hemosiderin staining, make sure you know that. That is a big question. That's a big thing on the exam that we often see. So this discoloration of the lower leg is hemosiderin staining. Why do they get that? Because that is going to tell you they've had chronic, long-standing venous insufficiency. The blood that pools in the lower extremity starts to break down, and what causes those red blood cells to be red leaks out and discolors the skin. So that's why they have that. How long does it take to appear? Ooh, I don't know, but it's got to be chronic. Like it's not something they would get probably within like the first 6 months or a year. I mean, this is somebody who's had it for a while. That's a good question though. It probably is patient dependent, but okay. I don't know if I did the polling, but we only have a few minutes left. So we're just going to go with it. We'll use chat. Patient arrives to physical therapy for shoulder rehab following a total shoulder arthroplasty. During the exam, you notice the skin eruption. Which of the following is your best course of action? Read through and let me know what you want to say in the chat, what your answer is. Awesome. You guys are great. You've got it. D. Yeah, it's that looks like ringworm. So I don't think they need immediate attention. I'm not just going to continue my exam as planned. I need to protect myself. I'm going to complete the exam, ask them to consult their primary physician prior to coming back to PT. I'm also going to clean whatever they came in contact with. I do not want the next person coming in to get ringworm. Good. All right, so that's an example of when a antifungal cream would be appropriate. All right, during a home visit, you observe this patient's legs. Based on the presentation, which of the following is most likely and concerning? Okay, we got to mix this stuff here. All right, so let's go through this one. Is it most likely they have venous insufficiency? Yeah, it looks like they do have venous insufficiency, and they do have hemosiderin staining. I see that on the right. It's probably also on the left. Am I most concerned about that? I don't know. I got to keep reading. An infection that requires hospitalization and intravenous antibiotics. This leg does look like it could be infected. So that is more concerning to me than the fact that they have venous insufficiency and hemosiderin staining. I'm more concerned that they have an infection and they may need IV antibiotics. Okay, I like B better than A. The left leg is swollen but not concerning. I am concerned about this left leg, so I got rid of C. Bilateral deep vein thrombosis, DVT. There could be a DVT on this left leg. That could be what's going on, but I don't see that swelling on the right, so I don't think it's bilateral. So I think B is my best answer. Oops. I got some kind of something going on. So does that explain that one well enough, or does anybody have any questions about that? That's A is very likely, B is very likely, C is incorrect, D is unlikely, but I'm most concerned about B. Okay. Yeah, this is probably actually cellulitis. That's what I think it is. And that requires hospitalization and IV antibiotics. But it could be a DVT. But either way, we need to get that checked out. So, but out of these choices, I like B. Yeah. All right, let's see what we got next. Yep, so this is just cellulitis. So, yep. Okay. A patient started physical therapy for impairments associated with psoriatic arthritis. The patient is afebrile, so they don't have a fever. They're now complaining of intense pruritus, which is itching on their legs, scaling, and patchy areas of redness. The physical therapist examines these areas. See the picture. Which differential diagnosis should we rule in? Okay, looks like we've got B's and C's. Yeah, it's not A. A is the term for athlete's foot. So I'm not looking at a foot, and it doesn't look like a fungal infection. Okay. Kaposi sarcoma is skin lesions when somebody has AIDS. It doesn't look like that either. So good, you got it down to B and C. This is actually contact dermatitis. They came into something that is an irritant, which has caused this scaly, patchy areas of redness. Okay. So sometimes they also call this eczema. It can be a precursor to other allergies or asthma. And it's caused by usually an irritant, an exposure or allergy. They can be dry, scaly, itchy. It's not contagious. And then they can be prescribed ointments to put on those. Okay, so, oops, I skipped too far ahead. Oh, okay, that's okay. We'll just go through it. because this was the other one, right? Patient arrives for physical therapy, reports pain and blistering on their face. See the picture. Why are they not sure why this has occurred? What is the best question to ask the patient? Yeah, this looks like it's herpes zoster, which is shingles. So have they had chickenpox? If they have this, the next time they're exposed to that infection, they will get shingles. Okay, were you doing lawn work this weekend? That doesn't look like poison ivy or anything like that. Did you burn yourself? It could be a burn, but they don't know why it happened. So I think if they burned themselves, they would know why that happened. And have you been treating this yourself at home? Although that's a good question, I don't think that's the best question to ask. We need to figure out what's going on and what to do for this person. And this would be a referral to their healthcare provider. Okay. So a little bit about shingles. It is reactivation of the chickenpox or varicella. It usually follows, it follows a unilateral dermatomal pattern. So it would never be on both arms or both legs. It's on one side. Most often it's on the face, the fifth cranial nerve, or the trunk. It has a great prognosis unless it spreads to the brain, which is rare. Heat makes it worse, but basically they're these fluid-filled vesicles. I mean, they look like little blisters, right? Painful. Sometimes the patients will have an intense itching, but a lot of patients will have pain. It is infectious, and so if somebody were to come into your clinic with this, you want to send them to go get that checked out and not come back until that's taken care of. Okay, it is 8 o'clock. So I'm going to wrap it up here. Again, we made it all the way through the interventions, and we made it probably about halfway through this one. This online office hour on integumentary pathologies is on YouTube, so you can check that out. And but any questions you have about what we went over tonight, please let me know. You can put something in chat or unmute. I do want to, really quickly, before you all go, I do want to show you, hold up. I do want to show you what's coming up on online office hours. So, okay, let me share this with you guys. All right, so these are the ones remaining for July. So next week is hip pain clinical practice guidelines. We're not going to have any on July 3rd. We figured probably nobody would show up. On the 10th is review of electrotherapeutics. And then right before the exam, the week before, is disorders of the elbow, forearm, wrist, and hand. Again, we have lots of these recorded and on YouTube, so please check those out. I hope this was helpful. Oh, thank you. Somebody put the YouTube
Thank you.
the link in there. Thank you. Have a good night, everybody. I'll stick around in case anybody has any questions about what we already covered tonight. Are there any videos specifically on differential diagnosis? I think when I go through the integumentary pathologies, just that in itself will help you with differential diagnosis. So like, for example, just talking about shingles, knowing that it's an exposure to an infection, that, you know, what it looks like, that it follows a dermatomal pattern, that right there helps you with the differential diagnosis. The big thing you want to know for differential diagnosis is venous and arterial insufficiency, which we went over that tonight with all those terms and we separated them. That's probably the big differential diagnosis thing. But yeah, if you went through the entire, if you go through the entire video on YouTube with the integumentary pathologies, I think that's all you need to know for differential diagnosis for integumentary. Oh, not just integumentary, but other areas as well. Yeah, so look on YouTube at all the online office hours we've done. I know I do one on pediatric neuropathologies. But we have several other ones that do. Actually, we have one, I think it was last week, that was, it's called masqueraders of musculoskeletal. So it's things that look like they may be musculoskeletal, but they're not. So that was probably all differential diagnosis stuff. Any other questions? Are we able to access the PowerPoint? It's just on YouTube. So you can see the whole PowerPoint on YouTube with the recording. Yeah, we don't give the PowerPoints out, but you'll see the whole thing on YouTube. Yeah. And other ones that are there are, we have one on, I do one on GI pathologies. That one should be up there. I do one on peds, neuropathologies. I do one on lymphatics. I think I give you everything in an hour that you need to know about lymphatics. We have several musculoskeletal topics. We have one on cardiac ECG strips, which I want to watch. I don't do that one, but somebody else does. I think we have one on obstructive and restrictive pulmonary pathology. So there's a lot of good ones on YouTube. Heather, you sent me an email recently. Did I get a chance to see it? I don't think so. What was the answer to the last question? Let me pull it up really quick. Let me pull it up and then Heather, I'll check. Okay. Share my screen with you. I think this was the last question. So it's B. Oh, Heather, I do see it. I'm sorry it got lost in my email. I will answer you. Okay, right away. Oh, the one before that. One before that. This one. Leslie, I got a response back. So if you're still here, I'm just going to read it to you because I did get a response back. 3 exams come with the ebook. Ask the student to look at the receipt they received. It should have information about the exams. If they're still stuck, please have them email me. I'm going to go ahead and put the email into the chat for you. Okay, there you go, Leslie. Thanks, Heather. I'll respond to you tonight. All right, anything else? Let's stop the recording.